Thank you for joining today's webinar hosted by Hologic, the significance of STI testing, Mycoplasma Genitalium, and opt-out screening for chlamydia and gonorrhea. My name is Susan Hepworth, and I will be facilitating today's webinar. Today's agenda is as follows. After my brief remarks, we will hear today's presentations from Dr. Tonya Chaffee, Clinical Professor of Pediatrics at San Francisco General Hospital. And then we'll also hear from Dr. Irene Stafford, Associate Professor in the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology at the University of Texas Health Science Center. Following their presentations, both Dr. Chaffee and Dr. Stafford will answer attendee questions, and then after the Q&A, that will conclude today's webinar. So please use the Q&A box at any time to submit a question. I will add questions to the queue, and they will be addressed at the conclusion of the presentation. So there's no need for you to hold your questions until the end. Please feel free to submit those at any time, and I will get them added to the queue. And with that, I will turn it over to Dr. Chaffee.
Hi, and welcome everyone. Thank you so much for joining us today. As you see, we're going to be talking about something other than COVID. I'm sure you guys are all happy about that. And quite frankly, I think this is sort of an endemic issue, testing and treating sexually transmitted infections that's been sort of underlying this whole pandemic that we've been in. And with that said, I'm going to start this presentation with going over the sort of the public health implications of where we are sort of post-COVID. I don't even say post-COVID anymore. Seems like we're always having to deal with COVID. And one of the kind of areas that I think I'm hoping you can leave today sort of understanding is what is opt-out screening for sexually transmitted infections and how do you implement that, or how can you consider implementing that in your practice? And then we're going to hear Dr. Stafford go through a really wonderful review of an infection that's been around for a while, but actually is something that now we can test for, Mycoplasma Genitalium. So as you probably know, testing and screening for sexually transmitted infections did go down during the pandemic. And this slide sort of highlights one of the things that we know. And I would say in 2019, all of these infections were on the rise, including chlamydia. So that now you see that chlamydia has actually gone down, and that is a result of the decrease in screening and testing for this particular infection. Interestingly, in my own county, we have similar decreased rates for chlamydia. We actually did a deeper dive and found that it actually correlated with significantly reduction in testing. We looked at our youth-based clinics where we were doing the vast majority of testing within our whole county, and they dropped by 50%. So if you don't test as much, you're not going to pick as many infections up. So although we do see that reduction in chlamydia, I think what's more alarming is that you see these increases in other infections where we know the testing also went down. So what's actually the kind of prevalence and incidence of these infections is probably a lot higher. What I do also want to highlight from this slide is that something that we did in our own county was really looking at health disparities, particularly in Black and African American women who were not getting as tested and often had high rates of these infections. We've been doing this for the last 5 years, although everything sort of dropped during the pandemic. But I do want to highlight just an age in and of itself puts a person at risk. So we know that the youth and young adults carry the largest burden, and I'll go into that a little bit more, but gay and bisexual men, as well as pregnant people, carry the largest burdens. And we'll talk about why that's significant. So although youth and young adults only take up about 13% of the US population, as you can see, they account for more than half of the chlamydia that is actually, and I should say that all these infections do get documented within your health department. If you send a test and it is positive, that gets reported to your public health department. So this data is very, very reliable. Doesn't matter what health system you're in. Those infection results do show up at the Department of Public Health. And youth and young adults cover up to 42% of gonorrhea cases. Why is this important? Why do we need to kind of diagnose and treat gonorrhea and chlamydia? Well, one thing we know is if you have an infection and it's not diagnosed and treated and it goes on, it can lead to PID. And we know this, but if you ever have a positive infection, that's something you usually want to ask is if that person's having more upper tract infections. And as much as 30% of women will go on to develop PID if they have gonorrhea or chlamydia. And then the really more expensive downstream cost to this is women becoming infertile and sort of the workup for that. And I will say I'm an adolescent medicine specialist, so I primarily only see youth and young adults, and I've been practicing for over 20 years. And within the last 5 years, I've actually been having patients now coming to me with fertility questions, and I did not see that in the first decade of my career. Some other consequences are, of course, chronic pelvic pain and ectopic pregnancies. And these are really why we have some screening guidelines, which I'm going to get into now. So, and these haven't changed. The CDC has come up with some new treatment guidelines as of 2021. And they haven't really changed. But I will point out something that gets into opt-out testing. So really the guidelines are that young, sexually active cisgendered women should be screened annually, not just once, but annually. So the risk factors are age, gender, and sexual behavior. After 25, it does kind of the guidelines recommend that you do some more risk-based assessment, which includes if a person's had a new sexual partner, if they've had a previous sexually transmitted infection, if they think their partners are having other partners, those women then should also be screened annually. As I mentioned, these guidelines have been out for several years, and they've also been sort of reaffirmed. Just to highlight them, I'll talk about the Human and Health and Human Services has a strategic plan to really dig down and kind of try to increase screening nationally. There are the treatment guidelines that were reaffirmed that we need to keep doing this, and sexually active women under the age of 25 screening annually. And then the U.S. Preventive Service Task Force, which really does this cost-effective analysis, like, is it something we should be doing? And I want to highlight, because gonorrhea and chlamydia are endemic in the United States, no matter where you live, even if you're in a rural area, it's there. And so it's still recommended that all sexually active women be screened annually. So this has actually gotten a little better as far as what are our screening rates and how are we doing. And this is assessed through various things. The HEDIS measure is one of them that they do recommend that this happens. So health plans are kind of held to account on how you're doing within your practice in your clinical setting. We're about almost 60%. But the HHS really has a goal to get to at least more than 2/3 of women are screened annually, and then by a 10-year goal of up to 77%. And one of the hard issues is because it's really, when we're talking about screening, and it wasn't really clearly delineated in the new guidelines, but they shifted from sexually transmitted disease treatment guidelines to sexually transmitted infection guidelines. And the real reason they went from disease to infection is because most people who have an STI, a sexually transmitted infection, they don't have symptoms. Disease implies you have symptoms. You have a consequence of your infection. So you're going to be presenting usually in a clinical setting because you have some sort of pain, dysuria, something like that. But most people who have an infection don't have any symptoms. So this is why it's really important to consider this, because most people who have gonorrhea or chlamydia aren't aware that they have it. And oftentimes when you are screening and testing them and you tell them that they have it, they're like, what? How come I have it? I don't have any symptoms. And this is why people who have the infection, not only are they unaware that they may have it, but they also are probably spreading it to other people who also won't have symptoms, so that they're not getting diagnosed. And this is why these infections continue to be seen at like 4.35% across the board. So currently, as you heard from our guidelines, one of the risk factors is what's your sexual behavior. And so that requires health professionals to sort of figure that out. And it's not all as easy as you can do in practice, particularly in my age population where there's confidentiality. Do the parents know? And we'll get into that. I think the other thing that's been coming out since we've been just doing risk-based screening or asking about sexual activity is that a lot of cases can be discovered in people who say that they're not having sex. So that can be an issue. And I think because we know this now, this kind of points to why we need to consider potentially going to universal screening or opt-out screening. And then with that, doing that risk-based assessment, there can be some stigma associated with, like, what kind of behaviors are you doing? And why are you asking me all these questions? Why aren't you asking everybody these questions? So and then we say, well, do you want to be tested today? It kind of puts this burden of like, why are you asking me if I want to be tested? Do you think something's wrong with me? That gets into sort of the stigma around how we do this. So I highlighted just a couple of little barriers, but I want to really go more deeper into some of these things to think about, because it sounds, easy to just go ahead and screen everybody, but I think it's important to think about what the barriers are and why we're emphasizing universal screening. So a lot of people, I have lots of my own colleagues, they say they know their patients, they know what they're doing, and they just may not test them because, I know they're not having sex. It can be time consuming getting a sexual history. And along with it, getting that sexual history with adolescents in particular, there can be issues around breaches of confidentiality. Is that information in their medical record? What if the parents find out? Do the parents have access to their medical record? Getting the parents out of the room and making sure you have time alone. There can be difficult conversations, particularly if there's positives. I often think that sometimes STI testing can be a fidelity test. If a person thinks that they're in a monogamous relationship and then this infection shows up. Sometimes people can perceive barriers around how you get paid or reimbursed for screening, which we'll talk about. There's lots of patient barriers. And I say the vast majority of young people don't know what these infections are, so they don't even think that they could get them. Again, there's stigma around sexually transmitted infections. We have wealth of research and information on this with HIV. Not having the time alone with an adolescent and having the parent in the room. Sometimes the parent may be the only one giving the history and don't even get any information from the young person. And then actually getting testing. So I think that's part of what can help, is when you as a provider can help a young person know what gonorrhea and chlamydia are and how they can test for it, and that they often don't have any symptoms. And I want to drive this home because there has been more than one study that's shown that patients who say that they're not having sex actually have chlamydia. It's up to about 1%. So that's a missed opportunity. So a lot of times I hear from people that, parents, they don't think that their kids should get this and that we shouldn't be talking to them about this. Well, actually, there's research out there that actually most parents really want you to have that time alone. They're hoping you're having that sex talk with them because they may or may not have had that with them. And a lot of parents actually expect this, well, yeah, of course, just, my kid probably should be tested. And I think this is important because this allows that time alone that we can have with the young person to start to develop that relationship. So we can explain to them what gonorrhea and chlamydia is. We can explain to them how to prevent these infections, like using condoms. And then we can tell them that even if they're not having sex, that they can come in anytime to get these tests done when they do. So one of the things we want to go deeper into is opt-out screening. And this was actually added into the new CDC Treatment Guidelines under the special population of adolescents, recognizing that sometimes adolescents aren't comfortable talking about their sexual behaviors, and that this was really something that can be considered. Because you may have young people who disclose that they're not sexually active when in fact they are, and that they actually may be infected with chlamydia. And I will say, since we moved to universal screening within our own practice, we did find young people were saying they weren't having sex and they were in fact infected. And I will do a little sidebar to say that we actually now, since we've implemented universal screening within our practice, we've actually identified young people who actually it was in the some abuse that was happening. And that was sort of an unintended consequence. And I know it's kind of a bigger topic, but I just want you to consider that when you do go to opt-out testing or universal screening. So as I mentioned before, if you're doing risk-based screening, you're just sort of asking a young person, hey, do you want to be screened today? Which kind of can feel stigmatizing to that individual, or seeing if they need to be tested versus just, what? We are testing everybody. What actually helps us in our practice is we have a little brown bag with a urine cup in it that kind of reminds the provider, like, hey, it's usually pre-ordered already, and we're just letting the person know that we're sending their urine today for gonorrhea and chlamydia. I think it's a good time to just say, we test everybody. It's something we do once you hit 15 years of age. It also can help in those situations, like if you have SIBs coming in and one may be a little bit older than the other and you're only testing one person, not the other. This way, when you're doing universal screening, they're both getting tested. So it's not like one person's only getting the urine test today. And again, what this does is it doesn't get into you having to do that risk assessment and asking about sexual activity. I will highlight, though, it is important to know if a person's sexually active. And I would actually, if they are sexually active, ask them about their sex behaviors, because you may want to consider extragenital testing. But for the average young person, this is what you're doing. You're not really getting that risk factor of their sexual behavior, just sending it. And you're sending it on all ages. And if they've had a test done, that will already be triggered into the system, so they may not have to get a test 3 or 4 times a year. I would recommend getting testing, as it says, for higher risk. including those who've had new sexual partners. And actually, when I do the universal testing, and if they say they're not sexually active, I say, you know what, we're just going to do this anyway. But if and when you do become sexually active, you do want to get tested and you want to get your partner tested and you want to do this every year. Well, sometimes people say, well, is this cost effective? Should we be doing this? Does it really increase the amount of infections that we can pick up? And we've known this with HIV. That is why the CDC has had the universal screening for HIV for a long time. In case you weren't aware, the recommendations are anybody over the age of 13 should have at least one HIV test in their lifetime. These are 3 studies that looked at different clinical settings, including emergency departments, family planning clinics, and antenatal care. As you can see, when they go to universal screening, you have large increases in the amount of tests that are being done. And that's really why this is being considered, particularly in the special population of adolescents, because you do increase testing when you go to universal or opt-out testing. And this is actually a study that looked at that cost effectiveness. So obviously you're going to be doing more tests. And this is looking at a modeling of looking at if you went to universal screening in a chlamydia prevalence population of just 2.7. I actually know our own chlamydia prevalence is around 4%. And if you implement more testing, you're going to pick up more infections, particularly those people that may say they're not sexually active and who actually are indeed infected. And you can, when you go to universal screen, you can actually almost half that. I will highlight, if you think about it, if you are only doing risk-based chlamydia testing in your public health department or where you live in your community, you probably don't have the actual rate of chlamydia. It might be a little higher because you're missing some of those infections. When they translated that into the cost, what you're doing is you're helping to avoid those long-term consequences of infertility and PID and ectopic pregnancies, and that this is actually going to be cost-effective, even though you may be doing more tests. I do want to also highlight, because this is a HEDIS measure, that is that annual chlamydia screening in women who are sexually active under the age of 25, it is covered under the ACA as a preventative measure. So there are no copays, there's no deductibles, and no coinsurance. And I think that's really important because that can be a barrier sometimes for an adolescent who may be coming in independently and need to get tested, that they don't have to worry about the costs of getting tested. This is a large slide, and it goes through kind of a detailed something to think about. And I do want to emphasize that for a lot of young people, those who are transitioning from being an adolescent to an adult, I think it's important for you and to think about how your practice is set up so that you can have that time alone with an adolescent and setting that new stage, that you're going to get more of that health history and health information from the adolescent and not so much from the parent or guardian. And the way to think about that is your waiting room kind of teen friendly. And I think one of those ways you can do that is having posters that actually talk about what is confidentiality and what is consent. Just to know, universally in every state, there are laws around what an adolescent can consent to, and that they have the rights to have that information when they seek care by themselves that they're consenting to, that it should be kept confidential, and there's HIPAA laws that are universal around that. But a lot of young people don't know that, and they're not aware of that. And that's where you can kind of introduce that even in your waiting room, that you have posters around confidentiality. There can be things that you can do to help you do this, like where you can give the urine in a brown bag, and that person can go and get their test before you even get roomed. This is where your medical assistants can kind of assess some of that, and it can be done before to help with that timing of them going to the restroom. But I think it's important when you do start to implement opt-out testing, you want to get confidential contact information. We found that it was a big barrier. We might not have a phone number or a way to contact the patient if it was positive, and you really want to know that you have that in front, and actually telling the person that we want to contact you, we want to do this privately if you don't want your parents to know. As well as kind of the other follow-up when you do have positive results, and how to treat them, and do that all confidentially. So this is just giving you an overview of some things to think about. And when you do the QI project, I will highlight one thing. One of the things we found was we had this line at the bathroom because we were doing exclusively urine-based testing. And we found that, well, hey, we could actually use vaginal swabs to do this. We don't, for women, we don't have to do just the urine-based test. So we actually now have more swabs, so there can be self-collection within the exam room. And with that said, there are a lot of great resources to help you kind of implement opt-out testing. And there's a whole digital toolkit that you can go to if you go to the website. There's letters that you can have to kind of help with your practice, let them be informed that, this is what we're doing, to send out to your 12 or 13-year-olds that they're going to have this time alone with a provider. There's things that we may be doing, like sending a urine test or sending an STD test, because we're doing this with all patients, as well as information on ICD-10 coding, so you can know how to bill so that the patients don't get copays. One of the ones we use quite a bit is the self-collection. So we have this in the room so that the patient can know how to take the swab themselves. And I will say that this isn't just for vaginal swabs. You can use it for rectal swabs as well. We use that. We have that in Leslie's laminated posters so that the patient can understand how to do it themselves. And I actually think most patients really approve. They do like to do the self-collection versus going to the bathroom for a urine collection. I went over quite a bit on sort of how to think about making your practice youth-friendly. These are some great resources. They also provide resources, not just how to work with adolescents and what the confidentiality and consent laws are in various states, but they can also help you set up things like chlamydia quality improvement projects, which is actually what we did within our own practice. This was a countywide thing, because we were trying to address some of the health disparities that we had. And we made it a QI project. We even had our residents in the training program part of this. And I can say before we implemented universal screening, we were only getting rates around 20 to 30%. After we implemented opt-out testing for gonorrhea and chlamydia, we went up to over 70%, and we've stayed there even post-pandemic. And that's been our it's an ongoing QI project, and we get every quarterly reports on how we're doing with our STI screening. So as I mentioned, if you do start doing more gonorrhea and chlamydia screening, you're going to get more positive results. And there were the whole new CDC treatment guidelines were pretty impressive, because there's a huge amount of changes. And I'm going to give you just a couple of the highlights for gonorrhea and chlamydia. If you weren't aware, there's a really, one of the overarching themes of the treatment guidelines is to have more antibiotic stewardship. And that applies to both chlamydia and gonorrhea. As you know, we used to use this one-time dose of azithromycin. That's really recommended as using an alternative. And first line should be doxycycline. And the reason for that is because actually doxycycline head-to-head with azithromycin is shown to be 100% effective. It actually, in cases of rectal chlamydia, which you may or may not know, and if you didn't do extragenital testing and someone was receiving anal sex, if they had a chlamydia infection, it's really, you should only use doxycycline, because azithromycin is not shown to be as efficacious. The hassle with that, obviously, is taking a pill twice a day for 7 days. So they kind of, in the special populations of adolescents, it can be that sort of shared decision-making, but ideally you want to use doxycycline first line. For gonorrhea, there was also a change. You probably remember you were doing dual therapy in the past. They really want to move away from using macrolides in general. So treatment for gonorrhea is actually dose dependent on weight. So a person who's under 150 kilograms should get the 500 IM. That's more than it used to be. And 1 gram for a person who's over 150 kilograms. So you have to get a weight to kind of decide which dose you're doing. There are alternatives for, allergies using gentamicin or azithromycin. And there is an oral dose. We do this for partner treatment if we can't have a patient's partner come in to get tested and treated of cefixime. It's really, there's issues with that because of efficacy for treating for gonorrhea, but it can be used in those issues when you might have to treat the partner. I will highlight one thing, though, and it's not on this slide, but it is important to make sure that you have a person who had gonorrhea and chlamydia get rescreened in 3 months. About 30% of people will get reinfected, and they get reinfected obviously because their partner never got treated. So that's something you always have to consider. The other thing I want to highlight is that you shouldn't have any unprotected sex for 7 days after you've been treated, as well as the partner. So you want to get the partner treated, and that's kind of introducing the concept of expedited partner therapy. Every state across the country has laws in place that allows for this. And it really gets into sort of some of the liability that may happen when you are not seeing the actual partner, but you want to get the partner treated. And we know that this is definitely very important, because it's not like strep throat. You're going to have someone else that's infected when you have the primary patient that you're seeing in your clinic. The CDC does actually support expedited partner therapy because it's been shown to decrease gonorrhea and chlamydia rates in women. Ideally, you want the partner to get tested and treated, but that can't always happen. There can be insurance barriers. And I will say that states are different on which the infections are and which patient population you can prescribe an expedited partner therapy for. So I won't get in the weeds in that, but it's just sort of important to know what your own state laws are if you're going to implement expedited partner therapy. They actually changed the laws recently in our own state where they actually are doing some education for pharmacists, because sometimes pharmacists aren't aware that they can actually get that if a patient is prescribed something, that they can give some of their medicine to their partner to get treated. And what we actually do in California, or we do in our own practice, is we usually give a double dose. So instead of giving a 7-day course of doxycycline, we give them a 14-day course, but we tell them to give half of the pills to their partner to get treated. So I just want to highlight that every state does have laws in place that helps with expedited partner therapy. It's something to really consider. And with that said, I'm going to turn it over to Dr. Stafford, who's going to do an awesome review on Mycoplasma Genitalium. Thank you.
Hello, everyone. My name is Dr. Irene Stafford, and I'm excited to talk to you today about another sexually transmitted infection, Mycoplasma Genitalium, absolutely titled correctly, a highly prevalent infection. So I think the best way to talk about MGen is to start with a case study. So let's get started. A 26-year-old G0 who presents to care with increased vaginal discharge and postcoital spotting for a month. The patient reports that she has a new partner over the same time period, uses condoms most of the time, but also relies on Depo-Provera for contraception. So her last pap smear was 6 months ago. Her pelvic exam, on sterile speculum exam, she has moderate mucopurulent discharge with a friable cervix. There's no discrete cervical lesions or anything like that on a sterile speculum exam. So this is a fun polling question. What lab testing would you like to perform? So at this time, so 1, A is chlamydia gonorrhea. B, testing for vaginitis. So yeast, bacterial vaginosis, trichomonas, and chlamydia and gonorrhea. C, testing for the same organisms, vaginitis, yeast, bacterial vaginosis, trichomonas, chlamydia, gonorrhea, HIV, syphilis, and viral hepatitis, or D, other. So we'll give everybody a few seconds to answer the poll question, and Susan will help us reveal our results.
We got a lot of results coming in, so maybe we'll just give it a few more seconds. Right now, it's looking like B is winning with about 52%.
So I will move on then, if that's okay, Susan?
Yep.
So B is correct. So you use the multi-test swab and you send for BB, trichomonas, chlamydia, and gonorrhea. You also offer the patient testing for HIV, syphilis, and viral hepatitis, and she's amenable to this. I think it's really important to understand that according to the CDC guidelines, we really are supposed to consider at least offering HIV, syphilis, and viral hepatitis to our patients that are coming for sexual health screening. We know that, like Dr. Chaffee said, that people are supposed to be screened for sexually transmitted infections yearly. But again, a lot of times people kind of forget about these other very important infections. So the gonorrhea, BB, and trichomonas come back negative, but her chlamydia returns as positive. So you call in a prescription for the doxycycline for 7 days, and you do send EPT for her partner. So the patient follows up again in 4 weeks to see you because she reports that her vaginal discharge is not resolved. Okay. On physical exam, a sterile speculum exam remains unchanged, and she still has persistent discharge with friability seen at the cervix. Okay. So what lab testing would you perform at this time? A, chlamydia, gonorrhea. B, testing for vaginitis, again, yeast, BB, trichomonas, chlamydia, and gonorrhea. C, testing for vaginitis, yeast, BB, trichomonas, chlamydia, gonorrhea, and MGen, or D, other.
Great, we're getting all the results in here. We'll give it a few more seconds and then I'll let you know. It looks like a big majority, almost 90%, are saying C.
Perfect. So you repeat the testing for vaginitis. So you do your chlamydia, gonorrhea, and so on. And so because you all got the polling questions right, and she does have persistent cervicitis. You add on mycoplasma or MGen as well. So the CT, the chlamydia, gonorrhea, BB, all the vaginitis comes back negative, but the mycoplasma genitalium, the MGen, comes back positive. Okay. Fortunately, you're one of the few that has access to resistance testing for MGen in your local laboratory. Okay. And this comes back as being macrolide resistant. Okay. According to the guidelines, you're going to treat her with doxycycline 100 milligrams twice a day for 7 days, followed by moxifloxacin 400 milligrams daily for 7 days. Okay. Fortunately, the patient's symptoms resolved thereafter. She is happy about her symptomatic resolution, but also asks about whether or not her partner should be treated. So another fun polling question, what would you advise this patient regarding partner testing? A, her partner should be treated empirically for MGen. B, her partner should be tested, and if positive, treated for MGen. And C, other. So we'll give it a minute. This is a tough one because I'm not even sure there's really a truly right or wrong answer. No, Dr. Chaffee and I talked about this back and forth about partner testing.
Yeah, we're getting quite a bit of fluctuation on this one, but it looks like B is coming in at about 63 or 64% right now.
So honestly, that absolutely makes sense. I mean, for all intents and purposes, we should probably recommend and refer partner to be tested and partner to be treated if he or she is positive. If you have the ability to test for resistance, it makes sense. If you know those resistance profiles, it's absolutely totally acceptable to phone an expedited partner treatment. I do this with my patients because I'm fortunately lucky to have a lab that can actually test for resistance for my MGen isolates that come back positive. So why are we just learning about Mycoplasma genitalium now? I would say that probably 90% of my patients have never heard of Mycoplasma genitalium. So honest to goodness, in the past, historically, 1970s and 1980s, we kind of knew that there was a pathogen or some type of organism that was causing non-gonococcal urethritis in men. And so historically, what we would do is we would assume after gonorrhea and chlamydia testing was negative that it's likely Mycoplasma genitalium, and we would just treat those patients with azithromycin. So in the 1980s, which isn't really that long ago, was our first successful culture of MGen. In 2015, as we started learning more about molecular testing for MGen, we realized, and the CDC realized, that MGen is actually an important STI pathogen. In 2019, I mean, it's just not that long ago, we actually had the first FDA-cleared nucleic acid testing platform for Mycoplasma genitalium. In 2021, on the new CDC Treatment Guidelines, the CDC actually recommended testing for MGen in certain populations. So the detection of Mycoplasma genitalium is really kind of had been tough. I mean, to begin with, it acts and looks a lot like other STIs. To be completely honest, it could be asymptomatic, especially in females. It does not have a cell wall. It's very small. You can't pick it up by microscopy, so it's not like you can do a wet prep on this. Culture, I think there's maybe 3 labs in the world that actually have the ability to culture MGen, and it takes months to grow that organism. So it's definitely not applicable in the clinical environment. So thankfully, we do have nucleic acid amplification tests now, and this is the overall recommended way to detect Mycoplasma genitalium in our patients. So again, it's hard to know, does this patient have MGen or is it something else? The reality is there's a ton of overlap between MGen and other STI and other, even yeast infection. For example, abnormal discharge, there could be, vaginal irritation, pain during urination and sex. And the reality of the situation is MGen is quite prevalent. As a matter of fact, it's 2 to 3-fold more prevalent than chlamydia. In our population, we found in Texas, especially Southeast Texas, that MGen is 3-4-fold higher than rates of gonorrhea and chlamydia. And again, it's just got a lot of significant overlap clinically. So what do we know about MGen in female populations? Well, for one, again, it could be as high as 30% in women with clinical cervicitis. In PID cases or pelvic inflammatory disease, it could be identified in up to 1 out of 5 women who presents with PID. So again, in the hospital setting, when you have someone or you have a patient come into the ED with probable PID, please remember to screen for MGen. And again, the younger populations tend to be more infected with MGen. Okay. Again, people who have MGen infection have a 2-fold increased risk of cervicitis, PID, and again, related infertility, tubal infertility. And there's some pretty strong data to suggest that MGen has been associated with adverse pregnancy outcomes, such as preterm birth. What about males? So MGen actually is a little bit more likely to be symptomatic in the male population. It is responsible for 40% of recurrent urethritis in men. Okay, the majority of men that have MGen infection do have symptoms of urethritis. So again, 1/4 of men who present with non-gonococcal and non-chlamydial urethritis have Mycoplasma genitalium infection. So what is the prevalence of MGen? So if you see here, this is in females. Again, you can see with Dr. Getman and Dr. Gato's study that the prevalence of MGen is really high, especially in younger populations, similar to other STI. You can even see it here in the 14 to 17-year-old population. But look, 18 to 20-year-olds, we're looking at really significantly high levels of MGen prevalence. So upwards around 16% of people who present for screening have Mycoplasma genitalium infection. So for males, it's not that different. It's also pretty high. When you see here with men that are screened, we don't have the 15 to 17-year-old age group there. However, you can see that it primarily affects younger populations, less than 30 and less of age. So what does the CDC say? So the treatment guidelines, again, it's great that we have guidance now regarding Mycoplasma genitalium, but again, I'm not sure, I think we're still kind of far from perfect there. The recommendation by the CDC is to test women with recurrent cervicitis, and it should be considered in women with PID. I will tell you that in my population, if people have a prior STI or presenting for a sexual health visit, I will talk about Mycoplasma genitalium with them and offer them testing. When we do gonorrhea and chlamydia testing, again, if it's negative, we're waiting a week to 2 weeks before we see them again. And then we talked about MGen and rescreen. And again, that therapeutic for MGen is 2 weeks. So we're looking at a prolonged course for someone who has MGen infection. So typically, depending on your population and depending on your the way that the prevalence of STI are in your community, I still feel pretty strongly about just testing women with cervicitis for MGen. But again, the CDC says women with recurrent cervicitis and PID. Okay. For men, it's recommended to test men for MGen when they have recurrent non-gonococcal urethritis. So what is the best way to detect MGen? I know that there's been a ton of molecular platforms that have been developed. We've had it in research labs and academia. We know that there's been several DNA and RNA tests. However, the RNA is probably the best method used to detect MGen, mainly because, again, the organism itself is small. It has 1 copy of DNA. When we use the ribosomal RNA, there's thousands of copies of ribosomal RNA, so you're picking up the MGen organism with higher sensitivity. In fact, by using the RNA platform, you're picking up 40% of patients that have MGen that might have been missed by DNA platforms. So one thing to consider is that MGen is on the CDC antibiotic resistance watch list. Personally, I think MGen has an incredibly high resistance to macrolides, looking at the data from not just the male population or females who get screened for STI, but also in pregnant individuals where we've done some really nice, elegant pilot work and seen that azithromycin resistant approaches 40% in low-risk pregnant women. And most male populations, it's about 50 to 50% have macrolide resistance. So again, this is why we recommend antimicrobial resistance testing. Unfortunately, we don't have an FDA-approved antibiotic resistance testing out there in the industry yet. However, I know this is definitely in the works. So how do we treat MGen? So if you're fortunate enough to be able to test the isolate for resistance, if they're macrolide sensitive, fantastic. You can do doxycycline 100 milligrams twice a day for 7 days. And you can follow this by a Z-Pack, which is essentially 1 gram for the initial dose, followed by 500 milligrams every day for an additional 3 days. If macrolide resistance, Or if resistance testing is not available, which unfortunately is the majority of the case, we start with 100 milligrams twice a day for 7 days, followed by moxifloxacin 400 milligrams once a day for 7 days. So should we be testing for other mycoplasmas? Actually, this came up at the ASM meeting here in Houston, where we had a ton of microbiologists talking about whether or not, the mycoplasmas is there any pathogenicity to these organisms, not only for women and for men, but also for babies. And the reality is we're just not there yet. Unfortunately, we're not able to, there's not enough research and not enough data out there to suggest whether or not these are significant pathogens for female genital tract pathology or for male genital tract pathology. So at this time, more research is needed. And again, this is supported by the CDC that suggests that we should not be testing for ureaplasma or Mycoplasma hominis, because again, we just don't have good data to suggest that it's important at this time. So this is a really fun peer-to-peer online collaborative site. It's called Doc Matter, and I've had a lot of fun on this site contributing to conversations about specific MGen cases. There's been a ton of MGen experts on this site, including Dr. Geisler from UAB. Sometimes Dr. Munson will hop on from Marquette, who will put in their 2 cents about Mycoplasma genitalium. So for those of you who are interested, there's the link. You could scan that QR code and hop on. So how can we test for MGen? So again, the rRNA-based tests are probably the best and most sensitive. So thankfully, Aptima multi-test will take care of all your vaginitis bugs, your organisms, and Mycoplasma genitalium. The Aptima urine collection, the yellow one there down at the bottom, is also absolutely acceptable for testing for any of these organisms and for MGen. I will tell you that the urine is not as sensitive as the vaginal swab. However, some patient preference, if they ask, then that's definitely what we should do. Every hospital, every clinic has its own platforms. So, reach out to your clinic staff to see which one you have. The ThinPrep, obviously the ThinPrep PAP will tell you for gonorrhea, chlamydia, and trick. It doesn't tell you for Mycoplasma genitalium, unfortunately. So, overall, the vaginal swab is really the preferred collection method to test for Mycoplasma genitalium. It's a very simple self-swab. You basically insert it 2 to 3 centimeters into the vagina, and I just twirl it once or twice, let it be there for 10 to 30 seconds. The patient can do this on their way out. Patient satisfaction is quite awesome with the vaginal self-collection swab. If you see there, 90% of women found this collection easy. Almost 80% of them preferred it over a pelvic exam. I don't find that too surprising. And 60% of women actually preferred it even over urine testing. So it's a very simple way. You could do it in the room, or the patient can do it on their way out in the bathroom or in their private exam room. So really, similar to what Dr. Chaffee is saying, it's time for call to action. To begin with, opt-out screening is definitely more effective than risk-based approach. To be honest, in cases of national cases of syphilis, up to 50% of women with syphilis infection reported 0 risk factors. So we sort of need to get away from this risk-based approach, given the fact that it does tend to stigmatize STI, and it does tend to alienate patients and make them feel confused and not really sure how to discuss screening with their provider. Again, opt-out testing, good signage, like Dr. Chaffee said, make sure that it's youth-friendly, because we do know that a significant proportion of our new STIs are in our younger populations. Again, opt-out screening is definitely a way to help screen and treat to prevent adverse health consequences, especially for fertility. Consider MGen testing, please. It is recommended for women with recurrent cervicitis, but again, for your patients that who are presenting for sexual health visits, there's absolutely nothing wrong with offering MGen testing. Of course, please consider it when you have a patient who you're seeing for PID symptoms, either in the ED setting, family medicine, if you're seeing them in the ER as a consultation. And check with your lab to see which multi-test swab you have and what your Panther system is running for results.
Well, Dr. Chaffee and Dr. Stafford, thank you so much for joining us today for these informative presentations and for answering all of the attendee questions. For those who are on today's webinar, you will receive a follow-up email from Hologic with more information about today's webinar. So thanks everybody for joining us, and have a great rest of the day.